Hello, everybody, to the webinar on prostate cancer imaging organized by the European School of Urology. I think of this very strange spring we had all over the world with the COVID-19 pandemic. It's a very good sign for us being back on scientific meetings, and I'm really happy and also proud that the EAU was able to switch the entire meeting that was scheduled in March in Amsterdam from a meeting where we were supposed to be there physically to a virtual meeting. And this webinar is the very first of this activity around the virtual EAU meeting, which will be in the mid of July. And you might have seen the schedule. There are many very interesting webinars coming up in the next weeks. And we choose one of the most hottest topics we have in urology, imaging of prostate cancer, to start with. And we have a very exquisite faculty today. It's Villeirs from Gent in Belgium, a very known radiologist in the field of prostate cancer imaging. And not less known is Schoots from Rotterdam in the Netherlands, also very well known in the field. And I'm very honored and proud to have them in the team and to talk today about prostate cancer imaging. We have 3 talks. The first one is Schoots talking about MRI prostate, indications, readings, and reporting. I will then address MRI-guided biopsies and fusion biopsies, and then Gerrit will talk about local staging and also the detection of recurrence, which is of course also a very important point. So I would like to invite Schoots to give his first presentation and to talk about MRI prostate, indications, readings, and reporting. Ivo, please.
Well, thank you, Jochen. It's of course a great honor to be invited in this EAU webinar. A lot to talk. Prostate MRI, where are we now? I think a major game changer was last year presented in the EAU guidelines that use prostate MRI before any biopsy. So use prostate MRI upfront in the diagnostic workup. And it was not only recommended now for men with prior negative biopsies, but also in biopsy-naive men. And it addresses an extra item. The MRI positive man then combines systematic and targeted biopsies, but also consider not to biopsy men in men who have a negative MRI. So these are pretty great game changers. So that was last year, but where are we heading? And before I continue, I will just start with some basic skills about prostate MRI interpretation and reporting. And I would like to do that with 2 cases. So first, we have a 70-year-old male, which has a normal rectal examination, a PSA of 8.1, prostate volume of 36 ml, with a PSA density of 0.23. So within the primary diagnostic phase, we did an MRI. So before I show you the results of the MRI, I just want to briefly touch upon what is important in prostate MRI. What kind of sequences do we use? So first we have the T2 weighted images, and that images focus on anatomical information. Very important sequence in diagnosing prostate cancer. The second sequence is diffusion weighted imaging. Diffusion weighted imaging focus on tissue density. So, and that tissue density is related to tumor, significant prostate cancer. And we have several readouts. You can call it a B800, a B1000, a B1500, or even a B2000. And that is dependent on the signal to noise ratio of the most advanced scanners nowadays. And if you combine these different readouts into a more quantitative map, you use the ADC reconstruction. So these 4 images are nowadays the core of prostate MR interpretation. But we also have dynamic contrast enhancement on the left side here. We also use sagittal images to locate where the tumor is at the base, apex, and we have also coronal images. So this is actually the hanging protocol that I'm using. So a 6-panel view to interpret the prostate. So focusing now on the yellow arrows, you see a lesion in the right peripheral zone, more or less in the mid-prostate. It's about 16 millimeters. Now, this is identified, which is fine, but now how are we going to report this in our report? How are we going to classify this lesion based on a system? And we use the Pirates classification system, a more objective way of interpreting images. And it was last year updated in the version 2.1. And Geert is one of the authors. It's based on a 1 to 5 scale, focusing on identifying clinically significant prostate cancer. And it's related to the ISUP rating on 1 to 5 scale as well. There are several ways to show how this classification is built up. But this is a nice graph that's on the radiologyassistant.com. Please go to that website for additional information. But what you see here is first at the top row, you see the prostate. It is differentiated in the peripheral zone and the transitional zone. And if we look at the peripheral zone, the most important sequence that we use is the diffusion weighted images and the ADC reconstruction. For the transition zone, it's the T2 weighted images. So that is important to recognize also in multidisciplinary team meetings when we describe these lesions. And what you see on a scale from 1 to 5, you see several different definitions correlating with the score. These definitions can also be interpreted in a more visual way. And I would like to show you this drawing. So for the peripheral zone, again, the diffusion weighted imaging are the most important. And what you see is by increasing the likelihood chance, the darkness on the ADC and the brightness on the high B-val become more and more important. Okay, so coming back to our case and focusing on the yellow arrows, this is what you can identify. If you look at the ADC, black, it's very dark on the drawing. You can identify already hyper intensity signal on your B800, and you can identify the hyper intensity on the higher B value. So this gives you an idea how you should interpret. And because of the size, it's more than 50 millimeter, it turned out to be a Pirates 5. This is the way we look at images, step by step, to give an objective score in daily clinical practice. This lesion was targeted by MRI-guided biopsies, and it revealed an ISUP grade 2 prostate cancer without cribriform growth. The second case is a 65-year-old male with a PSA of 3.5 and a PSA density of 0.08. Not a very high likelihood chance already based on clinical risk factors, but still, in this case, we did an MRI. And again, we have T2 weighted images, diffusion weighted images, with several readouts, and we have the ADC reconstruction. Okay, taking you through the images. First, we see the T2 weighted image shows some hyposignal intensity on the right peripheral zone. There are some more irregularities, so it's difficult to say only on the T2 weighted images that there is prostate cancer. And again, the peripheral zone, the most important sequence are the diffusion weighted images. On the lower B800, it's hardly identifiable a lesion in the right peripheral zone. There's a 2 or 3 microfocus visible on the B2000, and yes, it correlates with dark, with hypointensity signal on the ADC. Now the question is, how are we going to classify this lesion? Well, again, this is slightly difficult. First, we have to look at the B800. So this is hardly identifiable, right? On the higher B value, we see some small hyperintensity. Is it really that sharp as it corresponds with the Pirates 4? No, not yet. And the ADC, is it really that dark that we say it's definitely a Pirates 4? This is a difficult case. But dynamic contrast enhancement can help. As you can see here in the drawing, if it really focal enhances, we score it at Pirates 4. And therefore, we did the DCE. And here you see focal enhancement, and it turned out to be a Pirates 4. And a Pirates 4 means targeted biopsies. And in this case, it revealed 3 biopsies of Gleason 3+3 is 6, the ISUP grade 1, without preformed growth. Okay, so these were 2 cases how we should interpret it and report prostate MRI. But more important, because the MRI diagnostic pathway is only as strong as its weakest link, quality is one of the big issues nowadays. We need to have good standardizations, high quality prostate MRI to really deliver the clinical impacts of the MRI diagnostic pathway. So an air in the rectum is a difficult case for us because it distorted really the MRI images. And I will show you the case. Here you see from left to right, increasing air in the rectum. On the right, definitely a lot of air. On the left, hardly any air. And what you see here, these are DWI, these are diffusion weighted images. And what you see that distortion comes into play because of rectal air. You cannot interpret these kind of images. This is bad quality, and it should not be accepted for diagnostic purposes. And yes, there are some solutions for that. For example, you can use a microlax for getting the rectal feces and air out of the rectum. And you really see improvement of your images. Here's an example from our experience that here you see the distortion of the DWI images. You cannot interpret the peripheral zone adequately. So we did a patient recall. And look, here you see hyperintensity in the peripheral zone. Much brighter on the high B value. This is not an artifact. This is. And we were very glad that we did, because this turned out by targeted biopsy as an ISUP 4+3. Okay, other quality issues are movement of the prostate. Movement of the prostate, whether it's because of rectal air, rectal movements, or even small bowel movements, gives blurry images. And I have also to say, if the patient moves a little bit, you get really blurry images. And see on the right, if you rescan the patients after good instructions, or even after introduction of buscopan, a reduction of the bowel motility, then you have this crispy, clear images of T2 weighted images. And then you can identify more secure lesions that may be maybe prostate cancer. So within the European collaboration between urologists and radiologists, this document was recently published, and it is on the quality requirements of image acquisition. Very important paper. Please read it. I will not go into all the details, but it's about the first step in getting good quality images. It's about image quality. It's about interpretation performance. That's the performance of the radiologist. And it's about reader experience. Very important items to get trustworthy classification scores. So where are we going? That's what I promised you at the beginning of this presentation. I believe that we are going more and more into a personalized MRI-directed prostate cancer diagnosis. And please read this paper because it shows really how we could deliver the clinical impacts of the MRI diagnostic pathways. It's not because we can all draw very difficult flowcharts, no, but it addresses some important issues and how we should get the results of the MRI into the biopsy decision. And of course, Jochen will discuss this in the next talk, but I want to briefly touch upon that MRI may guide finally whether and what kind of biopsies are being performed. So you can decide for a detection-focused diagnostic pathway using targeted biopsies and systematic biopsies. This is the what is recommended by the EU guidelines, but you also can omit systematic biopsies, and we call it a triage-focused diagnostic pathway. So only MRI positive men will get only targeted biopsies. But you can vary on this, and you can say, okay, in MRI positive men, you can also do systematic biopsies, or you can skip systematic biopsies in MRI positive men and only do systematic biopsies in MRI negative men. But what I believe is that risk stratification before prostate MRI and after prostate MRI becomes more and more the standard. And because patient selection before prostate MRI is important based on the clinical parameters and on validated biomarkers. And you can decide whether you perform this kind of MRIs that I've discussed, yes or no. And based on the MRI findings, you will really dive into several options before you decide on biopsy strategy. And that's all based on the clinical priority, the patient priorities that should be done in a shared decision manner. Okay, almost there. So if you see here, the PIRUS classification on the upper row, then still this is what we intended based on guidelines. Perform biopsy in PIRUS 3, 4, and 5, and consider not to biopsy in very low risk men. But if you add risk calculators, for example, you can more and better stratify these patients, whether even in the low category, this patient really needs biopsies. For sure, patients with still a very high risk of prostate cancer, you should consider biopsies. But you have the chance to more tailor biopsy decision in the intermediate category. Okay, I want to end with the 5 golden rules of prostate cancer diagnosis concerning the MRI. So first, reserve the MRI approach and the targeted biopsies for men likely to benefit from treatment. So the purpose is, do not use it just as a screening tool. The second is carefully assess risk of significant disease using PSA metrics or use risk calculators before and after MRI. Do not offer immediate biopsy if the MRI is negative, unless other risk factors are present. Accept, when using MRI, that not all significant cancers are found immediately, and therefore you have to have robust safety nets for negative and positive cases. And last, use the MRI-directed biopsy methods that minimize overdiagnosis and improve risk stratification. Thank you. Jochen, back to you.
Wonderful, Ivo. Thank you very much. A very clear message, and I'm very much favoring what you just said. We have several questions coming in, and probably one of the most pertinent one is the question about the multiparametric MRI and the biparametric MRI. And one of the question is, do you use the contrast enhancement in all patients, which means you do a multiparametric approach, or are you using biparametric first, and then you switch to multiparametric MR if you think that the contrast enhancement might add additional information, might be helpful to solve out or to sort out a patient being pirate 3 or 4 finally.
So this is a very, very important topic, and it's, of course, full of debates. We started from the multiparametric MRI, and we see the advances. And now we would like to decrease, of course, the multiparametric into the biparametric MRI, because we see many, many advantages, especially at the operation level. Even patients really prefer biparametric over the multiparametric approach. But we need to be a little bit careful for that. We need to understand the additional value of contrast into the multiparametric approach or into prostate MRI. As I showed you, the second case, their contrast enhancement gives additional value in interpreting and classification of this lesion. So it depends really when you skip contrast from general practice. You need to be aware that you will miss cases or that you classify lesions differently. This first, I want to stress that, right? That is important. Second thing is, we know that contrast enhancement additionally has additional advantage only in the lesions in the peripheral zone. So yes, you can tailor whether you should give contrast or not based on what you read on a Pirate 3 or a Pirate 4 case. However, in daily practice, it's very difficult to do institutional patient recalls if you are not sure about the final classification and the biopsy strategy. So it should not be by omitting contrast that you get improved uncertainty in your readings, because then the urology community will, well, embrace or will not adopt prostate MRI how it should be. So that is actually two major important aspects to really consider to get rid of contrast. Yes, it has advantages, but realize what the added value is.
I think what we would like to see happening is that we have as little Pirates 3 as possible. So either it's a yes or it's a no, but not, I do not really know. And if contrast enhancement helps us to get rid of these uncertain cases, I think every additional information is welcome. And for us as urologists, of course, we would like to have more a clear message and not, well, actually, I don't know. There are some cases of this, but if additional information helps us to be more selective, I think that is very welcome. We might have one more time for one short question, one short answer. I think it's a very interesting one as well. The question is, when do we use multiparametric MRI? Is it in all patients? For example, do we have a high-risk patient, PSA 20, or a positive digital rectal exam, T3 disease? Clinically, do we still ask for a multiparametric MRI before biopsy, or are we going for a randomized biopsy instead?
Well, that's a good point. For just detecting significant prostate cancer, you do not need, in all cases, prostate MRI. That's for sure. If you have a real T3 based on your rectal exam, you have very high levels of PSA, you can say, why do I need an MRI to focus, to show me that lesion on the left side that I feel? However, I think, because it's not only for diagnostic biopsy decision, it's also for the next step, how to treat this patient. So at the end, especially in those cases that you proposed, I still would do a prostate MRI. So yes, that ends up that before any biopsy, we need to do prostate MRI.
Completely agree. It's the beauty of the one-stop shop. With one exam, we can get diagnostic and staging at the same time, fine-tune treatment afterwards. So I don't see the point why not doing an MR in these high-risk patients, because indeed it might help you then to better select the right treatment for this patient and improve maybe the treatment you offer to the patient right away or right afterwards. Sorry, might it be radiotherapy or surgery? I think for both it is of importance. I think we are running out of time for this first round. Thank you very much, Ivo. Very interesting. And just to remind you that you are invited to write the questions during the presentation already, not only at the end. So we have the questions coming in, and we might select then beforehand the most interesting ones. So the next question we are looking for, the last point we're looking for, is MR-guided biopsy and image fusion. You saw that we can generate these images, and what we ideally get is shown here on the left-hand side, which is the report coming from the radiologist. And what we really need is a standardized report that really provides us with all the information that we need then to decide whether we should take a biopsy and also to decide where we should take this biopsy. And this is what is recommended from the Pirates Committee. And you see here on the right-hand side a report that is not that old. This is 2014, but which I received in a similar fashion just recently, and it consists of 5 lines and a few words, and it's basically impossible to transfer all that information that you have here on the left-hand side with just a very short and prose-like report that will not be of any use for the diagnosis of prostate cancer. So you need really to ask your radiologist to provide you with a standard and with a maximum of information in order to get forward with the diagnosis of prostate cancer. And then, of course, we have the big question, how we get the lesion that we see on MR to the tip of our needle. And we might ask ourselves if we need to fuse or not to fuse. And the first option is, in order to do fusion, and is the cognitive fusion, what we call so. And what we do here, we have the report from the radiologist. Ideally, you will be able to identify the lesion inside of the MR pictures yourself, and then identify where it is localized inside of the prostate in order then to let your brain work and to then find this lesion again in the ultrasound picture and then go here for the target biopsies. And very frequently in the area that is suspicious, you will be seeing a heterogeneous ultrasound picture, not necessarily always hypoechoic as seen here, but a heterogeneous picture, which is then likely to be the lesion, and this is where you would stick the needle in, and this is where you would then improve the diagnosis of prostate cancer by using MR information. The next way to do it is based, or to let you help with software, with technology, and for this you would need to tell the system at a certain time point where you look at with the ultrasound probe inside of the patient. So you need a 3D navigation device, and this might be done with the help of an electromagnetic field or a mechanical arm, or you might also do it image-based alone, and at least theoretically it might be done with an optical or acoustic system, but the former 3 are rather more frequently used for these purposes. And then you can superimpose the pictures coming from MR to the live ultrasound picture, and this can be done in a rigid fashion where they just superimpose the pictures, and you can see that there might be some misalignment here, and you can do it in an elastic fashion where you adapt the MR picture to the ultrasound picture, just adapting to the contours that you currently have in the ultrasound picture, which at least theoretically should be more precise in order to show the lesion inside of the ultrasound picture coming from the MR information. In order to get this fusion done, you need to tell the system at a certain time point where the prostate is inside of the MR picture. So you need to do what we call segmentation or delineation, and that can be done manual or semi-automatic. So you need to tell the system where the prostate is inside of the MR picture. And you need to tell the system also where the suspicious lesion is inside of the MR picture. And then the same needs to be reproduced with the ultrasound picture. You need to tell the system where the prostate is inside of the ultrasound picture. And then the software will be able to fuse the pictures and to show you where inside of the prostate the suspicious lesion is. And unfortunately, the more systematic steps you need to take in order to make this fusion, the more likely it is that you will have a systematic error in there. And if you have an error, we end up with what we call a misalignment. You see that here nicely on this picture. This is the prostate on the ultrasound picture. You have here an hypoechoic lesion at the apex, whereas on the MR fusion is somewhere in between. The lesion is completely misaligned with the lesion that you see here. And no wonder that with such a technology and such a poor setup of the system, you will not be effective and you will not have high detection rates and a reliable diagnostic workup of your patients. And very important, you should not overestimate the capabilities of the technology, of the software. You should still use your brain and your knowledge. And what I consider these systems to be is rather a GPS system that brings you on the right street, but it's up to you to find the right house number, therefore the right address in order to get then the lesion, the MR lesion, to the tip of your needle. So you still need ultrasound skills in order to make it work. And you should not blindly rely on what the software provides you with technology, even though sometimes they are promoted as being the holy grail of getting to the MR picture with your needle. And then we have the solution to do it MR in bore, which means that you would do the ultrasound, the biopsy not with ultrasound guidance, but you would have a needle that is forwarded inside of an MR scanner. Not sure that this is really a solution for all our patients because it needs specific material that works in the magnetic environment of an MR scanner. It is cost intensive, time intensive, therefore resource intensive, and it's impossible or difficult to do an additional randomized course, which are still recommended at least for the first biopsy. So this might be the solution for very selective patients, but definitely not for all our patients. Especially in light of these data, there's a recent meta-analysis published by Villeirs in European Urology that nicely explores the performance of the different approaches that you might use: cognitive fusion, software fusion, and in-bore fusion. And when it comes to the detection of significant prostate cancer, you can see here that there is no significant difference between the detection rates. Whereas you can say that whatever tool you choose, actually the outcome is promising. But you need to be aware that this data that is used or analyzed in this meta-analysis is coming from centers of expertise and of excellence that all have extensive experience with all the different approaches, no matter if it's the cognitive biopsy, the fusion, the software fusion biopsy, or the MR in-bore biopsy. So you can say if you have experience with the system and you know what you do, you will have good results. And then it does not matter what kind of approach you use to get, again, the lesion to the tip of your needle. And this is also corroborated here in a very recent randomized trial, also by the same author, the Future trial. And they randomized patients to receive an MR in-bore biopsy, a cognitive biopsy, or a fusion biopsy, software fusion biopsy. And you can see here that actually the detection rates are really similar between all the patients. So there's no advantage for any of these approaches. And also always very interesting in this situation is to look at subgroups. Are there some situations where one of the approaches might be interesting? Very busy slide, but I will guide you through it. Actually, you might have small lesions and there's no significant difference in the detection rate between the techniques. You might have anterior or posterior lesions, no difference in the detection rate of these different with the different techniques. If it's in the peripheral zone and transition zone, there's no difference. And even in smaller prostates or bigger prostates, there's no difference. Again, if you know what you do, you're familiar with these systems, you have an expertise by using these systems, you will have a good and reliable result. But that you need this expertise is shown here on this, in this study here, that shows you the learning curve associated to a fusion biopsy approach. And this is coming from Oxford in the UK. And they started off with a detection rate at the very beginning of using this technology with 40%. That is not too bad. And by improving their expertise, they were doubling their detection rate to 80%. Amazing. 80% detection rate only by knowing exactly what you do and how to use the systems. And this is definitely a strong sign that you need expertise in order to have this pathway really working, not only coming from the MR information, but also then what you do with the MR information later on. And there are actually 3 landmark studies or 4 landmark studies that we need to discuss when it comes to MR-guided biopsies. And I would like to go briefly through all these 3 or 4 studies. And the first one is the French MRI First study. I would just shortly lay out here the design of the study. 250 patients, all biopsy naive. They all underwent multiparametric MRI, which could have been a 1.5 or 3 Tesla MRI. They all underwent a randomized biopsy by one operator, followed by an MR target biopsy by a second operator. And the outcome was the presence of significant prostate cancer. And these are the results, and actually they show that when it comes to the detection of significant prostate cancer, that's the green bars here, both approaches do achieve the same detection rate, but the randomized biopsy is detecting more insignificant cancers in addition to the significant cancers. And this is actually what we would like to avoid. We would like to find significant cancers and avoid to find insignificant cancers. And coming back to the decision tree that Ivo was offering, to use MR as a triage before biopsy, which means if an MR is negative, we skip a biopsy. If you would do this instead of this study, then you would spare a biopsy in 1 patient out of 5, which is actually not too bad, by still maintaining the same amount of detection of significant diseases. The second is the Dutch 4M study, pretty much the same approach, using 3 Tesla instead of 1.5 and 3 Teslas, and using MR in-bore biopsies instead of fusion biopsies that were used in the French trial, and the outcome was the same, a significant detection of significant prostate cancers. And they have pretty much the same observation as in the MRI First, similar detection rate for significant cancer between both arms, a significant higher detection rate of insignificant cancer in the randomized biopsy arm, or analysis rather, because all patients underwent both biopsies. And however, they were able to reduce the number of unnecessary biopsy by 50% if you would have used MR as a triage test, which means MR negative, you would not undergo a biopsy. But of note, it's important to see here that the individual biopsies actually add to the diagnosis. Some cancers are only diagnosed with the MR approach, others are only diagnosed with a randomized biopsy in both studies, as you can see here. And up to you then to decide if you would like to miss those cancers or if you consider them being relevant and you would like to have them also detected by combining both approaches together. And then we have the most famous one, that is the International Precision Study. That is a true randomized trial where they compare 2 arms, the first one being an MR arm, where only patients with a Likert score of 3 to 5 underwent a targeted biopsy and a targeted biopsy only. And the other arm underwent a systematic biopsy, 10 to 12 course, without the use of MR, and the endpoint was again significant disease. And they could actually show that with the MR-only approach, you will have a higher rate of significant prostate cancers relative to the randomized biopsy. And in the randomized biopsy, you will have a higher rate of insignificant cancer, ending up of having the overall same detection rate. But the beauty of this analysis is that you would avoid a biopsy in 1/3 of all patients if you would like to use MR as a triage test. So I think based on this data, we do what we would like to achieve. We find more significant diseases while at the same time missing insignificant diseases. But the question is, how good is MR to rule out the need of biopsy? How reliable is a negative MRI? And for this, we need to have a look at the PROMISE trial, which for me is the best study that was published in this field so far, where actually they had a look at patients that were candidates for a biopsy. They all underwent the index test, which is multiparametric MR. And after that, they all underwent a template biopsy, a mapping biopsy, taking biopsies every 5 millimeters out of the prostate. And this is probably the most reliable test that you can do in order to know if a patient does have prostate cancer or not, close to a radical prostatectomy, which of course is nothing you can do in these patients. And this was thought out to answer then the question what the negative predictive value of a negative MR will be. And we learned from this study that actually the results depend very much on the definition of what significant prostate cancer is. It does not change the sensitivities and specificities, which are somewhere around 90% for the sensitivity and around 40 or 50% for specificity, but it substantially changes the negative predictive value. if you take a very strict definition of significant disease being Gleason pattern 4+3 or 6mm core involvement, of note that very few patients fulfill only this criterion here, then the negative predictive value is at 89%, which means 1 patient out of 10 having a negative MR will have such a cancer miss, which for me is really fine. And this is something I can accept, 1 patient out of 10. But if you use a more common definition of significant disease, Gleason pattern 3+4 or ISIP 2 grade or higher, then all of a sudden the negative predictive value drops to 76%, which means 1 patient out of 4 will have such a cancer missed if you consider negative MR being a good triage test. And that is something where I would start thinking if I would like to accept to miss 1 patient out of 4 having significant disease with a negative MRI. And actually what we observe here based on this study is what is also shown by the prostate cancer guidelines panel from the EAU that did a very nice meta-analysis on the negative predictive value of MRI. And what they could show is that the negative predictive value depends very much on the incidence of the disease. The higher the incidence, the lower the negative predictive value. The lower the incidence, the higher the negative predictive value. In other words, it means you have a patient with a high risk of having prostate cancer who per definition belongs to a group of patients with a high incidence of the disease, and the MR is negative. You should not blindly rely on this. This patient should undergo a biopsy despite the fact that MR does not show a lesion. And in a patient with a low risk, who per definition belongs to a group of patients with a low incidence, you might rely on MR and skip then the need of a biopsy if MR is negative. And this is the data that from the PROMISE that nicely corroborates the observation that was done from the guidelines panel. And Ivo was already alluding here to the recommendations. I would not go here into detail again, but indeed they recommend to do a biopsy before any biopsy. The difference between the two approaches is that we should combine targeted and systematic biopsies based on MRI first and the 4M study when it comes to the first biopsy in lesions higher than 3. And in the repeat biopsy setting, you might do a targeted biopsy only and skip the systematic ones. And then if pirates 2 or less lesions are seen or the MR is considered being negative, you should decide whether to take a biopsy based on shared decision making with the patient, but also based on a shared decision making coming from other information, not only the MRI, but the digital rectal exam, the personal risk of the patient, and of course also of the PSA. So still use your brain and do not blindly rely on new technology and on MRI. And I was already alluding to this quickly. This is just to end this presentation. I think we cannot stress it enough. The performance of MRI is depending very much on the expertise of the radiologist reading and reporting the MRI. And you can see here the AUCs of the detection of prostate cancer coming from different radiologists, and only using the same patient by having a different radiologist, the performance might be weak at 0.69 or very good at 0.81, only because a radiologist is an expert or not. And if you're an expert, you have a lower likelihood to miss locally advanced diseases. Data coming from my center, they could show that an expert radiologist is unlikely to miss T3 disease on an MRI, very unlikely to miss high-risk disease, high-grade disease, primary Gleason pattern 4 or higher, and also missing higher volume disease. And this is actually what we would like to observe. But it's very important that you have an expert doing these MRs in order to make it work and in order to have an option to rely on negative MRI as a decision-making tool. In conclusion, I think it became clear that in order to make an MR pathway work, we need standardization, training, and quality assurance. And I think that is a very important point, and we need to work on this together from the urology side as well as from the radiology side. And the paper we just recently published in the European Journal of Radiology is the first step into this direction. Cognitive fusion seems to be comparable to software fusion if it is in the hands of experts. And MR-guided biopsy is better than randomized biopsy for the repeat biopsy setting and for the role of for the initial biopsy, especially also for the role of to be used as a triage test. It needs quality and expertise in order to be effective. And I think that is the most important message I would like to give here with this presentation. And I thank you for your attention. I'm happy to get back to Ivo and Kurt in order to do the discussion of this presentation.
Thank you very much, Jochen, for this excellent and very clear presentation. It was actually so clear that no questions came in, apparently. I don't have a question either, but perhaps just one addition. So there's the 3 ways of targeting a lesion. You can do the cognitive fusion, the the cognitive fusion, then the software fusion, and there's the IMBOR. What we do with IMBOR is just to reserve the difficult cases for the IMBOR biopsy, so the very small ones, and also the anterior lesions, because these are frequently the more difficult ones to target. And the IMBOR biopsy then helps to find those lesions better.
I completely agree with you that there are some unique cases where, but not unique necessarily, but some cases where IMBOR is indeed a good option, and probably everybody will be happy to have this option available. These are those patients where you have a strong suspicion, maybe they also have calcifications inside of the prostate that really hinders you to have a nice vision of the prostate, to see the details that might tell you then exactly where to take the biopsy, and there you still remain blind to what you would like to do. And then of course the perfect solution is to the MR IMBOR biopsy, because you get rid of all these limitations that are purely linked to the ultrasound part of the fusion approach. But again, I think the workload would be too much, and MR scanning time is too precious in order to burn it with a diagnostic intervention that might be easily done with other approaches.
Yeah, absolutely, totally agree. Okay, I think for the sake of time, we move on to the last presentation now. Which is about local staging and local recurrence detection. Okay, perfect. So let's start with local staging. Of course, you know, the gold standard for local staging currently is PSA and digital rectal examination and the Gleason score. These parameters are mixed in nomograms and formulas, and they give you a percentage chance of extra prostatic extension. Now, in the EAU guidelines, it is also stated that you can use the pre-biopsy multiparametric MRI to gain some interesting staging information. And indeed, on this pre-biopsy MRI, you can look at the location of potential extracapsular extension. You can look whether there's a tumor that is fixed to the pelvic sidewall, whether there's an vesical invasion of the distal urethral sphincter, all important information. Now, the question is, if we do this kind of staging MRI, how good are we actually? Well, I will show you 3 meta-analyses that have been published and that have integrated all data that we have on sensitivities and specificities for staging. And as you see, the results are pretty similar. They give us a cloud of sensitivities and specificities. And actually, if we look at the sensitivities, well, they vary between 15 and 100%. And if we look at the specificities, they vary between 0 and 100%. So really wide variations in these performance parameters. And the question is why? Why do we see these very big variations? There's a couple of reasons. First of all, there's actually no consensus on criteria for extracapsular extension. So it appears that, it appears that every institution uses its own criteria for calling something extracapsular extension or not. And the same for seminal vesical invasion. There's no consensus on criteria. And on top of this, there's also no consensus on imaging parameters, the way the images are acquired. Apparently, everybody does something else. That's, of course, a problem, and we have to solve that problem. First solution is that we need minimal requirements, standardization for the image acquisition of the images. And the first step in this were the guidelines issued by the European Society of Urogenital Radiology back in 2012, in which they stated that the most important sequence of the staging MRI is T2, is anatomy. We need clear anatomy images because staging actually is a purely anatomical thing. So good anatomical images with T2 weighted imaging, thin slices, 3 millimeter or even less, in 3 orthogonal planes, high in plane resolution, small fields of view, and also the use of peristaltic drugs because bowel movements can degrade the image quality. Functional imaging tools like diffusion and contrast enhancements, they are considered optional. They seem to be very useful in less experienced readers, but the more experienced readers can do perfectly with just T2-weighted anatomical imaging. So that's one step, standardization of the image acquisition. The second step is also a standardization of the recording. So what criteria will we use to call something seminal vesicle invasion or capsular invasion? Well, for seminal vesicle invasion and also for capsular invasion, we can use a kind of a timeline. The earliest signs of invasion, seminal vesicle invasion, are focal wall thickenings, as you see here. And usually you see this better in the coronal plane. Focal wall thickening. Then next you can see intraluminal masses, which are a clear sign of seminal vesicle invasion. And then also destruction of the whole seminal vesicle. Yeah, of course, this is a very clear sign of seminal vesicle invasion. Then for extracapsular extension, well, it all begins with a tumor that grows within the prostate, within the confines of the prostate. And as long as it is confined to the prostatic parenchyma and does not make any contact with the capsule, there's 0% chance of extracapsular extension. But then the tumor grows further and approaches the capsule. So then you can have a broad contact between the capsule of the prostate, here's the tumor, and here's the tumor capsular contact. The longer this contact length, the more chance of extracapsular extension. The tumor grows further and gains some more volume, and if it gains volume, then it pushes the posterior boundary of the prostate away. So this would be the normal prostatic capsule, but because of the tumor, it bulges posteriorly. So this capsular bulging is suggestive of some extracapsular extension. Then the next step is that the prostate grows within the capsule itself. Now the capsule, usually we can see this as a dark line, a low signal intensity line. You see it on the left side of the prostate. On the right side, this disappeared because it was destroyed by the tumor. There's another example here. You have a clear black line, which is the capsule on the left side, and there's a destruction of that capsule on the right side. So capsular signal intensity disruption is also an early sign of extracapsular extension. Then once the tumor grows beyond the confines of the prostate, when it has grown within the capsule and beyond the capsule, then malignant cells will grow next to the prostate in the periprostatic fat. And then the margin between the prostate and the periprostatic fat becomes unsharp. And when these malignant cells clump together and form bigger areas of tumoral tissue, then you get an irregular contour. Tumor cells grow further and further away from the capsule and will infiltrate the periprostatic fat. This is the next step in the evolution. And when this happens in the rectoprostatic angle, here you see the rectoprostatic angle on the left side, it's between the posterior border of the prostate and the anterior border of the rectum. Well, here it has completely disappeared because the fat is obliterated by tumoral tissue. And then the final step is that you see macroscopic tumors or measurable tumor in the periprostatic fat. Clearly, you see a time here. You see early signs in yellow over the orange one to the red ones, which are the later signs. And this clearly has a time evolution. It goes from purely intraprostatic to purely extraprostatic. And basically, you consider three groups here. The first group is the tumors that grow really within the confines of the prostate. You see them in the prostate, in the parenchyma with no capsular contact. So these purely intraprostatic tumors, they are clearly definite T2 stages and we put an I before it, an I for imaging, so not clinical, not a C, not a P, but an I for imaging. So it's an imaging T2. That means intraprostatic. That means, for instance, active surveillance can be possible. Nerve-sparing surgery can be possible. On the other side of the spectrum, we have the major extracapsular extensions. And these are the diagnostic signs for major extracapsular extension. There is some overlap, but the majority of these ones show that it is really purely extraprostatic tissue, extracapsular extension here, seminal vesicle invasion there. This is very clear. It's an imaging T3. So this is absolutely not a candidate for active surveillance, not for nerve-sparing surgery, or not even for surgery. Perhaps this is a patient who is a candidate for radiotherapy and androgen deprivation. And then in between, we have the most difficult staging and imaging. That's the in between with these early signs. This is very difficult and it's very frequent also. You can see slight capsular irregularities, slight capsular undulations. Well, it can be a sign of extracapsular extension, but you are not 100% sure. These are the criteria that can be found in these situations, and these are called the potential T3 stages, the potential local invasions. It's very interesting to know this. Potential T3s do not necessarily need to change the therapy plan that was envisaged, but you, as urologists, you want to know this. You want to know whether there's probable extraprostatic extension, because then active surveillance might not be a good solution for the patient. Also, if you want to do a radical prostatectomy, you want to know if there's potential extracapsular extension. Where is it? Is it on the left side, the right side, the apex, the base? Because you will not do a nerve-sparing surgery in that situation, and you might even take a broader margin in order to have clean margins afterwards. So it's very important that you have this information, even in those situations when it is not 100% sure if there's capsular extension or not. And then we move on very quickly to local recurrence detection. Is there a local recurrence within the prostate? Imaging will have its role, but it will depend on the prior therapy that has been used, like radical prostatectomy, radiotherapy, or focal ablative therapies. If we first look at radical prostatectomy, well, of course, after radical prostatectomy, the anatomy has changed. The prostate has been removed. We have a bladder neck, which can be round or rectangular or irregular. And we will see perianastomotic fibrotic tissue with low signal intensity. Then we will see an empty seminal vesicle fossa because the seminal vesicles have been removed. Usually we see some scar tissue, some fibrotic strands, sometimes also clips that have been left in place. Although the fibrotic tissue can be a bit coarser, you can have thicker, linear, low signal intensity streaks, like here. But you can even see remnants of the seminal vesicles. And actually we see this in about 1 out of 5 cases. They look like the native seminal vesicles. They are filled with fluids. They have high signal intensity on T2. And of course, surgical clips, we can see many of them also in the prostatectomy bed, and they degrade the local magnetic field a bit, so they cause some artifacts. Now, if we use MRI to find a local recurrence, we have to take into account the PSA. This is very important. In the low PSA ranges, the pickup rates will be very low. And only when we go further, 0.72 or 1 nanograms per mil, then the chance of finding something with MRI, local recurrence, will be reasonable. We look for these recurrences primarily in the perianastomotic and in the retrovesical area, highest chance of finding them there. And the initial manifestation on anatomical T2-weighted imaging is a lobulated hyperintense mass. So it's white and it contrasts well with the dark signal intensity of the fibrosis, perianastomotic fibrosis. Nevertheless, the diagnostic performance of just T2-weighted imaging is not very good. Sensitivities are too low. We have a lot of false negatives. We miss a lot of them. And so the specificity is not also very good. We have many false positives due to residual benign prostatic tissue, etc. So it's clear that T2-weighted imaging is absolutely not sufficient to find a recurrence. Diffusion-weighted imaging can help. In diffusion-weighted imaging, you will see a diffusion restriction if there is a recurrence. Diffusion restriction is very similar to the primary setting also. And early reports showed very good sensitivity and specificity. But be careful, the PSA range was quite high, 0.3 to 2 nanograms per mil. Later studies with lower PSA ranges, well, they showed lower sensitivity, 70%, and the incremental value, and that is very important, the incremental value was not so very high. It basically means that if you see something on diffusion-weighted imaging, then you have already seen it also on T2-weighted imaging, so it doesn't really help. Also, the quality of DWI frequently suffers from susceptibility artifacts due to the numerous clips that have been left in place. So DWI is not the best option. DCE, on the other hand, dynamic contrast enhancement, this really helps. It shows enhancing areas that correlate with recurrences, and then we can find these recurrences back on the T2-weighted images. Without contrast, we would miss it. In a meta-analysis about DCE for recurrence after radical prostatectomy, the pooled sensitivity was high, about 90%. The specificity was also high, about 90%. And these absolutely are the best results so far. So the recommendation here, if you want to find a local recurrence after radical prostatectomy, do the multiparametric MRI, in which dynamic contrast enhanced imaging is absolutely the dominant sequence. And also take into account that the positivity rate will increase with increasing PSA. Then, after radiotherapy, we have a different situation. The prostate is still there. It just has been irradiated. And because of this irradiation, you see a diffuse decrease of signal intensity on T2-weighted images. There's atrophy, there's fibrosis, and because of this, the signal intensity drops. And this is a bit annoying because this drop in signal intensity, this black area, well, recurrence also is a black area, so black on black is a bit difficult to find. So you can totally miss a recurrence in this low signal intensity prostate. That's the reason why the sensitivity of just T2-weighted imaging after radiotherapy is very low. It's 25 to 45%. It's clearly not enough. Also, the specificity is not so very exciting. So clearly, again, additional techniques are absolutely needed to find a recurrence after radiotherapy. Diffusion-weighted imaging, well, this helps. It shows a diffusion restriction, the diagnostic performance of that is very, very good. It's 65 to 95% sensitivity. Also, the specificity is very good. Do not have too many false positives here. And this better performance of diffusion-weighted imaging, when you compare this to the situation after radical prostatectomy, is of course due to the fact that we still have a background to compare with. There's still a prostate, and we can see diffusion restrictions as compared to normal diffusion areas in normal areas. Also, there's an absence of surgical clips, which is also very important because the image quality is not degraded. That's the reason why DWI performs much better. And then we can also use contrast, dynamic contrast enhanced MRI. It enhances and it shows a recurrence here on the left side that is difficult to find here on the T2 after brachytherapy. You see the brachytherapy seeds. Diagnostic performance of contrast, while the sensitivity is good, between 70 and 100%, and also the specificity is quite good, 75 to 85%. However, it only works in a peripheral zone. It's inferior and transition zone. This is exactly the same as in the primary diagnostic setting, where DCE doesn't work well in the transition zone. Also, you have to wait about 3 months after the radiotherapy, because otherwise you can have inflammation that enhances with contrast. Recommendation here after radiotherapy is that you use multiparametric MRI, but with DWI and DCE as the dominant sequences. Then finally, the focal ablative therapies. Well, it doesn't really matter whether you cook or whether you freeze the tissue. It all comes back to the same thing. The prostate shrinks and the zonal anatomy gets totally lost. It's a bit similar to the situation after radical prostatectomy. After radiotherapy. So if you just do T2-weighted imaging to find a recurrence, you won't find it. Also, DWI is not so very specific. DCE gives the best results so far, but there's very scarce literature on that, we have to say, and therefore the recommendations are based not on literature but on a Delphi expert consensus, where it is stated that you need multiparametric MRI with DCE as the dominant sequence. And that brings me to my take-home messages. For staging, while MRI can show a definite intraprostatic tumor or a definite extraprostatic extension, which has its therapeutic consequences, but it can also show the site of potential extraprostatic extension, which usually is microscopic extension, or at least extension of less than 1 to 1.5 millimeter beyond the prostatic capsule. Radiologists should use a standardized technique and standardized reporting for that. For local recurrence, well, after radical prostatectomy, DCE is the dominant sequence. After radiotherapy, DCE and DWI. After focal ablative therapy, also DCE. That brings me to my final slides. Thank you.
Yes, Geert. Thank you. Great talk. We have several questions, and I would like to start with the first one. So you really described very carefully and in detail the posterior tumors that have extracapsular extension. What are your recommendations for anterior tumors? Do you have some guidance for that as well? What kind of imaging characteristic should we be aware of?
Yes, that's a very, very good question, but difficult to answer because there are no clear guidelines, and you have a totally different setting there. Posterior and lateral to the prostate, you have a capsule. That's very clear. But anteriorly, you do not really have a capsule, or you have a capsule that merges with the anterior fibromuscular stroma. Anterior fibromuscular stroma is kind of a fibrous shield on the anterior side of the prostate. It is non-glandular, it's purely fibrotic, and it's about 3 to 5 millimeters thick. And what you can see is if there is a tumor in the anterior horn of the peripheral zone, or there's a tumor anterior in the transition zone, it can infiltrate the anterior fibromuscular stroma. And then you look at the thickness of the anterior fibromuscular stroma. If you have a full thickness disruption of the normally low signal intensity of the anterior fibromuscular stroma, then you can call this a total breach of the stroma, and this can be a T3 disease. If you see residual low signal intensity anterior to the tube, to the invading tumor, then you can call it a T2.
Okay. There's an extra question about using nomograms. Of course, urologists use nomograms. How do you see the role of MRI included in nomograms or separate from nomograms? What is your opinion about that?
Well, for the time being, we need to do what I was talking about here. We absolutely need the standardization first. If we have the standardization, then we can make a kind of risk stratification. You've seen the timeline. You have seen early signs, later signs. The late signs are really the signs that hold a high positive predictive value for extracapsular extension. We have done this in our own institution. The early signs have a positive predictive value of about 40 to 50%. Then you know, okay, if I see these signs, the probability of extracapsular extension is not that very high. But the later signs that you see, like the obliteration of the rectal prostatic angle, for instance, this has a positive predictive value of more than 90% for being extraprostatic extension. So in that way, we can come to a kind of a pirate score like we have for diagnosis, but then for staging. Then you will have a risk assessment based on what you see on the images.
Jorgen, from the audience, several people are very interested how ADT reflects or influence the MRI images in the recurrence status.
Yes, well,
no, sorry. After radiation, and then in the recurrence status. Yeah.
Yeah. Well, but they have the same effect. So what they cause is a metabolic atrophy. So what you see is that the glandular tissue does not behave as glandular tissue anymore. There's very few fluid production, and so the signal intensity drops. Exactly the same as what you see after irradiation. You have a grayish prostate with no clear differentiation between peripheral zone and transition zone anymore, and it makes it more difficult to find a cancer recurrence on T2-weighted imaging. Of course, you have DWI and you have DCE, and they do not have this same problem. They can really find a recurrence. So it's basically more a problem of anatomical. It's more an anatomical problem because of the metabolic atrophy.
Okay.
Okay.
I think for the sake of time, we're running a little bit over time already. We need to stop here. Thank you very much, Gert and Ivo, for the excellent presentations. As always, pleasure to work with you. And for the audience, I would just like to remind you that there is the questionnaire to be filled out if ever you would like to have the CME accreditation for this webinar. And of course, I would like to invite you to join also the other webinars coming up now in the next weeks here up until the EAU meeting, which will be on the 17th to the 19th of July in a virtual fashion. And we will also have the theme week afterwards, which will show posters and other events around urology. And I think we managed to have a very nice program together, and I think this will be very attractive for you. And with this, I thank you very much for your attention. I'm very happy that you joined us here, and again, enjoy this month to come of virtual urology organized by the EU. Thank you very much, and goodbye. Have a nice evening, and stay safe, especially in this very specific time we have worldwide. Thank you very much. Bye-bye.